Okay, so it's three, two, one. We are live to the audience. We can start the meeting. Over to you, Parthasarthi sir.
Very good evening, one and all. Very good evening, fellow doctors. Uh, we are very happy to have each and every one of you out here. As you all know, one out of seven diabetics worldwide is Indian, as per the latest IDF data. To throw more light on the same and therapies herein, we have with us an esteemed panel of gurus who can give you information on the same. I have the honor of introducing our esteemed moderator for the day, Professor Dr. Shashank R. Joshi, who is an endocrinologist at Lilavati Hospital and Bhatia Hospitals, Mumbai, respectively. Sir is currently the chair IDF of Southern Asia and the president of the Indian Academy of Diabetes. His past positions were as past president of the RSSDI, the Endocrine Society of India, and the Association of Physicians of India. He was also the past dean of the Indian College of Physicians. He's been awarded the most honorable Padma Shri by the Government of India in 2014, the International Clinician Award at the 21st AACE, Annual Scientific and Clinical Congress in Philadelphia, as well as the Healthcare Visionary of the Year at Indian Affairs Leadership Conclave in 2014. He is also in the editorial board of various journals. He is editor emeritus of the Journal of Association of Physicians of India and past editor of the Indian Journal of Obesity, Indian Journal of Endocrinology and Metabolism, and the Indian Journal of Clinical Pharmacology and Therapeutics. He has over 800 research articles published in peer-reviewed journals, and he has authored more than 100 books. Dear sir, it's an honor to have you with us. Over to you, sir.
Thank you, Partha, for your kind words of introduction. Today we have a cardiometabolic conclave, and it's our honor and privilege that Professor Clifford J. Bailey, who is a good friend of India and an extraordinary teacher par excellence, has agreed to join us virtually. I wish there was no COVID, and I wish he was here physically. We would have loved to host him up here. We all know that Professor Bailey is the Professor of Clinical Sciences at the Aston University in UK. He is one of the founding members of the ESD ILED study group, the British Endocrine Society, the British Pharmacology Society, Diabetes UK, ESD, International Society for Diabetes and Vascular Disease, whose journal he edits with some cutting edge science. He's also a fellow of the Royal College of Physicians and Pathologists. He's currently the senior editor of Diabetes and Vascular Disease Research, which is his foray, and also pharmacology. He has been the endocrine section editor of the British Journal of Pharmacology and editorial board member of Diabetes, Obesity, Metabolism, Lancet Diabetes Endocrinology, and Primary Diabetes Care. He has more than 400 peer-reviewed original research and review papers. He's an extraordinary clinician and pharmacologist both, and he combines it with extraordinary teaching skills. So I'm sure that over the next maybe half an hour, a little more than that, he is going to tell us some cutting-edge science on controlling the dual cardiometabolic risk, which is so pertinent as we talk in 2022. And as I said, that he would then be followed by an extraordinary panel we have from India, and we will have a very good dialogue between our experts from Professor Jhargar, Dr. Das, Dr. Mehrotra, and Dr. Pancholia, and everybody else who is there. And we will have a very nice interaction on the same. So I would now request Professor Cliff Bailey to really start his presentation over the next 30, 40, 45 minutes as he pleases. He's, as I said, one of the best speakers on planet Earth when it comes to teaching clinical medicine and clinical diabetology. Professor Bailey.
Thank you very much indeed for a wonderful introduction. I'm very grateful. I'm sitting here in the UK, and I hope you can all hear me okay in India. So it's a delight to be invited. Our title is Controlling Diabetes and Cardiometabolic Risk, and we're going to be focusing on SGLT2 inhibitors and DPP4 inhibitors. And we're going to be taking our examples mainly from dapagliflozin and vildagliptin, as we'll see in a minute. These are my disclosures and disclaimers. I've got no conflicts to report. I was involved in several of the trials in the early days with dapagliflozin. Here is a quick summary of the lecture forthcoming. A quick reminder at the beginning of the cardiorenal aspects of diabetes type 2, as well as the metabolic aspects, the value of timely intervention to reduce complications. Then we'll have a look at the guidelines and the sequence orders of the agents that are used in the treatment. Then we're going to focus in on SGLT2 inhibitors, and particularly dapagliflozin, then on the DPP4 inhibitors, and particularly vildagliptin, and then we're going to combine them together. So a quick reminder to start with of pre-diabetes, because we're dealing here with a progression, and often we don't recognize pre-diabetes, but the glucose is really the key element here, that it is creeping up close towards diabetes, and we know that that is often associated with that increased cardiovascular risk, and we might also be starting to think about kidneys. But once the HbA1c has gone over that boundary of 6.5% and we've got early type 2 diabetes, then it's a case of trying to definitely keep the glucose under control. And we know by then we have a much higher cardiovascular risk, and we want to try and prevent that reduction in glomerular filtration. But typically, because this is such a progressive disease, these balloon out to give us, first of all, this characteristic sequence of metabolic disturbances, of which obesity is a very common element. Insulin resistance is almost invariably present. Of course, the hyperglycemia, dyslipidemia, and too much fat in the kidneys. And on the cardiovascular side, it isn't very long before we start to see some, or in some cases, essentially all of the cardio problems that are listed here, but particularly hypertension, hypercoagulation, atherosclerotic cardiovascular disease, heart failure, and acute coronary syndromes. And also we see these renal problems, particularly the emergence of chronic kidney disease and albuminuria. And if you look in a typical clinic and see that typical type 2 population, at least a quarter of patients seem to have cardiovascular and or chronic kidney disease. They've usually got more albuminuria. Virtually 2/3 to 3/4 will have hypertension, and we know that there's an increased risk of cardiovascular mortality. There will be emerging microvascular complications, and for example, we know that diabetes is the largest single category on the dialysis register. So should we have seen this coming? Well, the answer is yes, because at the time of diagnosis, we generally find that about a quarter of patients already have a complication, and we can see that as time goes by, for example, microvascular complications in each of the studies that have been reported in the literature show an increase with time. So you could track this back, and we know that during pre-diabetes, there's been a period of time when these microvascular complications have been coming on. And in fact, looking in pre-diabetes, we can see that insulin resistance is invariably present. Something that's often forgotten is that this is the time of renal hyperfiltration, when the glomerulus starts to get damaged. And as shown in DECODE, an increase in cardiovascular risk. And we can also see evidence of retinopathic disturbances associated with hyperglycemia. So what's behind all this? Well, it's a complicated story, of course, because we have many tissues with many different defects. These tissues listed here are all contributing to type 2 diabetes in the majority of cases. So the pancreatic problems of B-cell dysfunction, excess glucagon, the gut problems of defective incretin action, altered microbiome, disturbances of the autonomic system, insulin resistance. I'll come back to this one as time goes on, the various comorbidities. Obviously, obesity in so many, pro-inflammatory syndrome, and altered glucose handling by the kidney. All of these are contributing, these being the two main ones at the top, the insulin resistance and the B-cell dysfunction. And we tend to address this with the lifestyle issues for, all the way through, first and continuing. But because we've got multiple defects in multiple tissues, we often need multiple therapies. And each of these shown here in the mauve, but particularly metformin, addressing the insulin resistance, sulfonylureas, raising insulin secretion, DPP-4 inhibitors, GLP-1 receptor agonists, SGLT2 inhibitors are the main ones that we're tending to use. And you can see they've got a main focus on different aspects of the disease pathogenesis. And then at the bottom line, of course, insulin. So we've seen the cardiorenal components quickly. Now let's have a look at the value of timely intervention. And if we have a look at any of the big trials, and of course, coming from the UK, I'm going to pick the UK PDS, we can see the value of each of the treatments here, lowering HbA1c, but we're dealing with a progressive disease, so there's a creep up over time. This is over 10 years. And an average reduction here with any of the treatments of around about 0.9% A1C. It might not sound very much, look, a decrease of 0.9%, but it produces massive benefits in terms of a 25% reduction in microvascular disease, a reduction in macrovascular, a reduction in any diabetes-related endpoint, and of course, a reduction in all-cause mortality. And if we just dissect in this study how many patients had an HbA1c less than 7%, which I think is a reasonable marker of good control, then we can see by 3 years, more than half of our patients are failing to get control. And by 6 years, fewer patients are getting control, and by 9 years, fewer still, about a quarter are getting control. In other words, at 9 years, about 3/4 of patients would be requiring combination therapy. How successful are we? Well, in the UK, this is our last major audit evidence, and it shows us that at this time, we're only getting 2/3 of our patients with an A1C here of around 7.5% or less. We're getting quite a lot of patients' blood pressure and cholesterol's under reasonable control, but we're only getting 40% of patients with all of those three categories under control, indicating that the cardio element as well as the metabolic element together are not being very well served. So we're not doing so well in the UK. I had a look at the data in India, and I've got the data up to 2017 in the literature. And if we look across on the left-hand graph, we can see, just like the UK, large proportion of patients are having A1C values that are over 7. And if we look at the individuals on monotherapy, dual therapy, triple therapy, or more than 3 agents, we can still see large numbers of them here in the light blue with an A1C over 7%. So there's clearly a need to bring these values down. And if we look at the microvascular complications with time, we can see them creeping up over this 5 years, particularly in India. The neuropathy is a major concern. And if we look at the agents that have been used, the TIGHT study tells us what we've just seen, essentially, that the majority of patients are requiring 2 or 3 glucose-lowering agents. And at 217, it was, of course, major use of metformin, also DPP-4 inhibitors, and the newer agents like SGLT2 inhibitors just emerging. And we'll see how they're getting on a little later on. So let's have a look at the guidelines now. This is the latest ADA EASD guideline, tinkered with in the ADA professional committee's documentation. It's quite complicated. So rather than go through this version of it, I've tried to produce this version, which is a simplified version, which essentially says lifestyle first and continued, generally metformin first. When it comes to adding your second glucose lowering agent, have a careful look at whether or not the patient has atherosclerotic cardiovascular disease, heart failure, or renal disease, or is at very high risk. And if so, then depending upon what is the most risky, you might choose one of these first of all as your choice of agent. Then you will obviously take account of what you would normally take account of if the patient did not have evidence of cardiovascular or renal disease, which is avoiding hypoglycemia, and all of these agents offer that benefit. Trying to control weight in the overweight, and these are the preferenced agents. Or if it's a cost issue, certainly in Europe and North America, it's likely to be one of these. Why do we still keep metformin at the top of the tree? Well, just to remind us, not only does it reduce glucose levels very effectively, but as you can see here from the many studies that have been conducted of cardiovascular events, it tends to reduce cardiovascular events. And this is an analysis of 750,000 patients in 21 studies, showing a pretty consistent reduction to the point of about 17% in these studies. And if we look at heart failure and then consider in these patients whether or not they survived, you can see good survival in heart failure patients with metformin. So we're getting benefit here, a reduced mortality. And that reduced mortality is of about 20%, but it comes with an important reminder at the bottom, which is that although metformin can be used in mild conditions of heart failure, if that heart failure is very severe and is likely to cause hypoxemia, then that, remember, is a contraindication. So now let's have a look at the SGLT2 inhibitors, and I'll take the examples from dapagliflozin. On the left-hand side, you can see the table showing that we've got dapagliflozin, canagliflozin, empagliflozin, ertagliflozin. Here, I believe you have more in India, and they all work by inhibiting the reuptake of glucose by SGLT2 in the proximal tubule. They may have a minor effect, but it is a very minor effect on the uptake of glucose by SGLT1, which is in the last straight segment of the proximal tubule. So they all cause glucosuria, which is essentially attacking the hypoglycemia to get the glucose level down by removing it in the urine. By inhibiting SGLT2, they are acting independently of insulin. So they will work whether there's beta cell dysfunction, insulin resistance, or any other element causing the hypoglycemia. And what we normally see is that the glucosuria rises very quickly to start with, and then it falls off as the glucose level falls off. So we're getting a reduction in the glucosuria over time. This is, of course, associated with a reduction in the glucose level, as shown by the HbA1c. We know that this is getting rid of calories, which is causing the reduction in body weight. And it's also associated with an osmotic diuresis, which is reducing the systolic blood pressure. There is very low risk of hypoglycemia because we have SGLT1 as the safety net, as well as some activity still of SGLT2. And because this action is independent of insulin and is different to any other of our agents, it's compatible, so can be used in combination with any of our other agents. Here is just an example from dapagliflozin showing that glucosuria up here, showing the reduction in A1C in the blue here, showing the associated reduction in body weight here, and the reduction in systolic blood pressure. Many of the SGLT2 inhibitors are looked at in terms of the way in which they've performed in the cardiovascular outcome trials. So each of them has been involved in one of these CVOTs, cardiovascular outcome trials, and CANA has also been looked at in patients with renal impairment. That was in Credence. So all the patients had type 2 diabetes. Now, this little table is going to show us, first of all, the cardiovascular problems with these trials. And you can see that in some of them, all of the patients had cardiovascular disease or a history of it, whereas in other studies, only a modest number of patients had cardiovascular disease. So although we tend to compare all these studies, in fact, they have quite considerable differences in the populations studied. Now, we're going to have a look at the primary endpoint, which was the 3-point MACE, major adverse cardiovascular event, which was either cardiovascular death, non-fatal MI, non-fatal stroke. And I've also added in here the hospitalization for heart failure. And I'll put in the numbers, but you don't really need to look at the numbers. Everything was on the right side. There were fewer major adverse cardiac events. And if they were statistically significant as primary endpoints, they're in dark green here. And if you look along the bottom, one of the most consistent significant findings was that there was a reduction in hospitalization for heart failure. Now, here's the little table that we've just seen with the duration of follow-up actually added in on the bottom. And because there was this consistent benefit in reducing heart failure, studies were then undertaken, and they're listed here, in patients who had heart failure. Initially, these were all with a reduced ejection fraction, and we can see that the primary endpoint of worsening heart failure and cardiovascular death was consistently reduced. So very considerable benefit. Following on from that, we have two studies looking at preserved ejection fraction. The first one has been published a year or so ago, which is with empagliflozin, again showing a reduction in the primary endpoint. And we've just heard that the one from with dapagliflozin similarly has a reduction in that primary endpoint. It was only announced last week, so we're still waiting to see the numbers. And when those numbers come, I will be able to fill in the rest of this table. What is so intriguing is, yet again, in patients with heart failure, we see a reduced hospitalization for heart failure with these drugs. And that effect was much the same whether the patients did or did not have type 2 diabetes. If we just look at that heart failure effect here in the DECLARE-TIMI study with dapagliflozin, you can see that it didn't take very long before these lines diverged, and they've kept on diverging throughout a long period of time. This is 1 year, 2 years, 3 years. So you can see that it is a very consistent effect, a 27% relative risk reduction. Interesting during that study also with dapagliflozin was reduced renal events. This was a renal composite looking primarily at EGFR reduction and avoidance of end-stage disease, and it prompted further studies. And this is the DAPA-CKD, where dapagliflozin was looked at in patients with renal disease, and we can see again a reduction in renal disease as indicated by this renal composite. And in particular, that renal composite is associated with a slower reduction in EGFR. And if you were to extend these lines out for a long period of time, you can see why the dapagliflozin is reducing the long-term risk of end-stage renal disease. And also supporting this is the evidence from this trial and many others now that the dapagliflozin reduced the albuminuria. This is, of course, a class effect. I'm showing the data from the dapagliflozin studies, so we can see that it is a consistent effect of SGLT2 inhibition. And trying to piece that all together, you can see here how the glucosuria is able to not only reduce the glucose and the weight, but also offers those benefits against blood pressure to reduce it, and is often offering renal protection. And there are additional effects on the bottom shown here to directly affect the cardio and the renal events in diabetes. And in consequence, we can see quite clearly here that if type 2 diabetes is a cardiorenal as well as metabolic disease, then the SGLT2 inhibitors are able to provide benefit against several of the metabolic, several of the cardio, and several of the renal events. The mechanisms we don't have time to go into today, but I'll be happy to discuss them, particularly the effect on tubuloglomerular feedback. Then we come to the DPP4 inhibitors, just to remind us of the incretin effect and the way in which they work. So we take a meal, this stimulates GLP-1 and GIP, which are able to enhance glucose-dependent insulin secretion. GLP-1 also suppresses glucagon. It's able to induce satiety and slow down the onset of gastric emptying, and these effects combined are able to reduce hyperglycemia. The problem is that DPP4, dipeptidyl peptidase 4, an enzyme in the circulation and on endothelial cells, very quickly degrades these two hormones. So what we're doing with the DPP4 inhibitor is inhibiting this enzyme so that the endogenous incretin hormones can have their full effect to reduce hyperglycemia. We have several of these DPP4 inhibitors in Europe. I believe you have one or two more in India. Really, they all have much the same effects. The only differences really are the way in which they're metabolized and the way in which they may interact with other members of the DPP group of enzymes. And if we look at meta-analysis, and there are several of them, of DPP4 inhibitors, first, their ability to reduce HbA1c, we can see here that they all do it, and vildagliptin seems to have performed particularly well. And they're usually considered to be weight neutral, although in general, during these different studies, there has been just a small reduction in body weight during their use. Most of them have had cardiovascular outcome trials, and they've all been neutral. Nothing terrible to report. There was a small increase in heart failures in one of the studies, but there's probably a good reason for that being a quirk of the way in which the study took place. But if we look at vildagliptin, which does not have a dedicated cardiovascular outcome trial, but we look in the database studies and the meta-analyses, we can see that again, it tends to be neutral, but on the beneficial side, where each of these numbers, or most of these numbers, are just slightly below the 1. So one of the key studies that's recently taken place with vildagliptin to look at its value is the Verify study. And just to take it as an example, patients were run in on metformin, and then they either carried on metformin, which was the sequential strategy, because only when they failed to keep their A1C below 7% was vildagliptin added, or they were randomized to combination study right at the beginning, where they got the combination of metformin and vildagliptin right from the start. And if we look here at the percent of patients with an event, this is percent of patients with, if you like, failure to keep their A1C below 7%, so their A1C crept up above 7, we can see that the combination here in blue kept those glucoses down much better for much longer, compared with starting off with monotherapy and then only adding in the vildagliptin when the glucose level had crept back up. And in fact, the monotherapy, we can see time to failure was about 3 years, whereas if you started off with the combination or used it very early, then we can see that we're dealing with more than 5 years of being able to keep the majority of patients under control. And we can see that there's benefit quite early on in the system, because there's about 15% of patients in the study who never did achieve adequate control on one agent alone. And the gap gets bigger as time goes on, indicating quite clearly that the benefits accrue with time. Now, looking at cardiovascular outcomes was not a primary concern of this study, but it's noted that if you look at the combination therapy, there are fewer cardiovascular events. In fact, although there are small numbers because the patients were well looked after, you can see that the combination right from the beginning was able to be associated with a lower number of cardiovascular events. And if we look at the effects on EGFR, and there have been studies on all of the different gliptins, but we can see here, vilda, like the others, no significant detrimental effect. And in fact, in 1 or 2 studies, we're seeing evidence as shown here that you can actually get a reduction in albuminuria. So half the studies, the patients in this study were able to get a reduction in A1C and a reduction in albuminuria. Quite a few of them got a reduction in albuminuria, even if they didn't get a significant reduction in A1C. So we can see those double benefits. And there were 1 or 2 who got a reduction in A1C, no change in albuminuria, or no change in either. So what happens if we put our SGLT2 and our DPP4 together, usually with metformin? Well, the combination of 2 agents usually allows you to use lower doses of 2 agents, which means you're likely to get fewer side effects. As we've seen, you can get greater efficacy for longer. You can create a wider range of beneficial effects against more pathogenic factors, and you can use these agents usually against more comorbidities. The adverse side of this is that usually adherence is a little bit more difficult with combination therapy, but fixed dose combinations can help this along, and there may be more monitoring required. And of course, there is sometimes a cost element, although in most of the fixed dose combinations, actually the metformin component at least would be free. And we can see then overall a considerable number of benefits to be borne in mind. And the way in which these agents can act in a complementary nature is illustrated here by the fact that type 2 diabetes, as we said right at the beginning, being multifactorial, is particularly associated with insulin resistance and beta cell dysfunction, creating the hyperglycemia. And the metformin tends to address particularly the insulin resistance. DPP-4 inhibitors are addressing particularly the pancreatic problems, B-cell dysfunction, and the SGLT2 inhibitors are addressing the primary problem of the hyperglycemia itself through the glucosuria. So you can see how they are complementary and can be additive with each other. And of course, new to India now, we've got a Vilda DAPA fixed dose combination tablet. So in summary then, we've seen how type 2 diabetes is more than just a metabolic disease, it's also a cardio-renal disease. Timely intervention can reduce complications. We have guidelines that make this clear and say lifestyle, metformin and SGLT2 inhibitors and DPP-4 inhibitors are particularly recommended depending upon the presentation of the patient. And we've seen those metabolic and cardio-renal effects of SGLT2 inhibitors and DPP-4 inhibitors and how we can put them together because they have complementary mechanisms of action. I hope you found it interesting and enjoyable. Thank you very much for your kind attention.
Thank you so much, Professor Bailey, for a wonderful exposition and wonderful presentation of all aspects related to cardiovascular disease, cardiovascular outcomes related to anti-diabetic drugs, with special focus on SGLT2 inhibitors and DPP-4 inhibitors and its combinations. We have a wonderful panel here, which I'm going to now introduce. And it gives me a great pleasure to introduce one of our founding teachers in endocrinology, Professor Abdul Hamid Jargar. He's a senior consultant endocrinologist at the Center for Diabetes and Endocrine Care at Srinagar. He has been the past president of the Endocrine Society of India, very active in Diabetes India and various diabetic associations. He was a past chairman of the Department of Endocrinology. He has not only shaped and does cutting-edge science and research in diabetes in India, but also has shaped the national health policy. He had been the director and ex-officio secretary to government in the Sher-e-Kashmir Institute of Medical Sciences and was also on the governing body of the world-famous All India Institute of Medical Sciences. Then we have with us another colleague of mine from endocrinology world, a professor at the High Tech Medical College in Bhubaneswar, Dr. Sambit Das, very, very active member of our Endocrine Society of India. He's our young brigade evidence-based endocrinologist, very active in IJAAD, IJEM, and various other journals. He is the secretary of the Endocrine Society of Odisha and RO Odisha chapter. He was the scientific secretary for SECON. He has been an inspirational endocrinologist in 2019 and the Times Health Icon Award. He does a lot of cutting-edge clinical trials in phase 3 and has several publications, abstracts, and book chapters to his credit. So that is from the endocrine world. And then, of course, we are dominated by cardiologists because SGLT2 inhibitors now are having a strong and stiff competition from cardiologists and nephrologists. So we have Dr. Sanjay Mehrotra. He's a senior consultant endocrinologist from Narayan Rugnalaya at Bengaluru. He's really an expertise in endovascular treatment for aneurysms, particularly the dissecting aneurysm, thoracic. He is also an expert in myocardial septal ablation, carotid interventions, percutaneous aortic valve implantation. Very active member of the Central Cardiovascular Society of India, Cardiovascular Society of Karnataka, a member of the Texas Heart Institute, and is a proctor for the endovascular treatment for aortic stent grafting. He has worked both in the UK, in the Western General Hospital as a senior registrar in Edinburgh, and then a visiting fellow at the Texas Heart Institute in Houston. And he's currently an assistant professor of cardiology at the St. John's Medical School in Bengaluru. Our next cardiology colleague, we You have the next slide, please. He's a very close friend of mine from Ahmedabad, Dr. Samir Dani. I hope he has joined now. He has an emergency right now, and that's what he had just messaged. He's a CEO of the Apollo Cardiovascular Heart Failure Heart Institute in Ahmedabad, director of cardiology in Apollo Hospitals in Bhat Gandhinagar. Continue that slide. He might join us later. Samir might be, cardiology word is a tough word. He was a former HOD of cardiology at the UN Mehta Institute of Cardiology in Ahmedabad. Again, very, very active BC Roy awardee, a lot of publications to his credit. And then, of course, we have finally with us Dr. A.K. Pancholia. He's from Indore. He's the head of Department of Medicine, Clinical and Preventive Cardiology at the Arihant Hospital and Research Center in Indore. He has organized the CSI Heart Failure Congress. He has been a former associate editor of the Indian Heart Journal. He's currently the convener of the Rheumatic Heart Disease Council of Cardiology Society of India. He regularly reviews for Indian Heart Journal. He always does the abstract grading for the European Society of Cardiology Congress for the last 5 years. And is a very well-known speaker, researcher, and teacher par excellence. Has written several and authored several textbook chapters in cardiology textbooks and cardiology updates. So we have now currently at least 2 cardiologists and 2 endocrinologists. And I'm going to go back to them for a dialogue and then come back to you, Professor Bailey. So I will start with our cardiology colleagues, and I'll start with Dr. Pancholia and Dr. Mehrotra. First to Dr. Pancholia, how do you view a combination like a vildagliptin and dapagliflozin, which is now generic in India, affordable and accessible? Do you think that the standard of cardiorenal care would definitely see improvement? And do you see that these drugs being increasingly used? Because India is one country where we still have a lot of secretagogues and metformin still being used, a lot of traditional old agents still being used. And with the elegant outcome data which Professor Bailey presented, Professor Pancholia, what's your first take on this group of agents which are now being launched and they are affordable, accessible by companies, for example, like McLeod's?
Thank you, sir. It is an ideal combination of the patients with a high risk of cardiovascular disease, having multiple risk factors, or having the atherosclerotic cardiovascular disease established. As we have data from the landmark trials that declared TME58 with dapagliflozin, and then we had a dedicated trial in REF patients, DAPA-HF trial, and now we are having the trials with the PEF also. So clearly they showed a clear benefit in patients with the high risk of cardiovascular disease, having diabetes or even without diabetes. So that is related to the dapagliflozin. With the vildagliptin also, as the trials clearly showed a neutral effect, not having increase in the cardiovascular events nor decrease, having all the neutral effects are there with the vildagliptin. And now with the combinations, as Dr. Bailey already shown, there's a substantial reduction in the HbA1c and reduction in the events, cardiovascular events, and the renal events also, because dapagliflozin also showed reduction in the renal outcome in declared TME58 trials and also in the dedicated trial in renal patients like DAPA-CKD, where we had an overwhelming response and therefore it was prematurely terminated. So it's a good combination in these high-risk group patients, particularly in India. And now as both drugs are off patent, so they are available in the cheaper price, the compliance and the adherence will definitely be improved in Indian patients.
Great. Thank you so much, Dr. Pancholia. Dr. Sanjay Mehrotra, Dr. Pancholia did make a passing mention. With the affordable, accessible, off-patent generics of Vilda and DAPA now available, and more drugs in this space getting off-patent, with the emerging evidence, do you think your practice in the cardiometabolic space as a cardiologist has changed when it comes to managing diabetes? And do you think that addition of these drugs and this data, pretty compelling data, has made a change in the last decade? How have you seen diabetes care evolve in the last decade from a cardiologist tunnel of vision?
Thank you very much. First of all, as far as the treatment of heart failure is concerned, with or without diabetes, there is clear recommendation even from the ESC. The 4 drugs which we have to use, and the DAPA has become part of it, which is very, very important, along with ARNI, beta blockers, and the mineralocorticoid receptor antagonists. So I feel, and there has been a substantial, evaluation and understanding about how these patients improve. We have seen in our clinical practice, the patients who have come with heart failure, even with reduced ejection fraction, becoming, heart failure free, number of hospitalizations have come down, their ejection fraction improved. So there is no doubt about it that DAPA has had a definite, association with improvement in the patients of heart failure who have established coronary artery disease. And so my concern is that I am not very sure about whether, the Vidagliptin would be available for use as per as my understanding as a cardiologist is concerned. And mind you, I have stopped treating diabetes completely. We refer it to diabetologists. So my thinking is that I think Vidagliptin probably, unless there is more evidence, as a cardiologist, I will probably stick to DAPA at this moment. I don't know what will happen if there is more evidence. And maybe Dr. Bailey can suggest and guide us on this, that would there be, of course, when you have, a patient who has a cardiometabolic state where there is obesity, central obesity and insulin resistance, a metformin may be a better choice, but I'm not sure about what will happen with the Vidagliptin. Although I think you as a diabetologist see that the number of patients who have controlled diabetes, even with heart disease, are extremely low. I see most of our patients, their HbA1c is more than 7. They're actually hovering around 8. So if you want to bring a better control of their, hypoglycemia or HbA1c, I think in such patients, Vidagliptin should have a role because it is reducing your HbA1c more effectively, in addition to the DAPA. So I am not very sure about usage in cardiac patients of Vidagliptin, but you can guide us on that.
Sure. So we'll come back to Dr. Bailey in a minute. Samir, are you there? Would you like to make an overarching comment before you go into your procedure, or you think I should go back to our endocrine colleagues? Dr. Samir Dani.
I think it's not there.
Yeah, he's there connected, but okay. So I go to Dr. Sambit Das. Professor Zaragar always has the last word, and of course, Dr. Bailey will have the last word. But Sambit, Dr. Sanjay just made a very passing remark that the A1C control is poor, but our glucose-centric vision has moved into cardiorenal protective vision. So how do you look at that? And how do you view a dual or a triple combination as a primary combination? And then, of course, we'll have Dr. Zaragar's inputs, and then we'll come back to Professor Bailey in what Sanjay has been alluding to.
Yeah, thank you, sir. So as you have mentioned that our approach to diabetes has actually moved from glucocentricity to more of addressing the cardiorenal aspect of diabetes. So definitely glucose control is one of the major feature. And the importance of a combination of DP4 and SGLT2 inhibitor lies with the fact that the combination is better in terms of controlling the blood glucose. It is better in terms of reducing the complication of individual component of that. For example, a combination of SGLT2 and DP4 inhibitor to some extent it has shown to reduce the genital mycotic infection and genital tract infection. So that's one of the other advantage. And plus it has got complementary mechanism of action like the DP4 and SGLT2 inhibitor. They complement each other in their mode of action. At the same time, if at each stage of diabetes, whenever the A1C is more than 1.5% the target range, I think addition of a DP4 with an SGLT2 inhibitor, for example, here it's the Vildagliptin with a dapagliflozin is one of the better option to add over and above metformin.
Fair enough. Dr. Zaragar, any comment from you? One major issue, Dr. Zaragar, I would like you to address is that you think that this is evolving, SGLT2 inhibitors are evolving as standard of care in type 2 diabetes management, and how early can you start them? Particularly with these combos coming up, how early can we start them?
I'll tell you, Shashank, if you look back, as endocrinologists, we picked up use of gliptins very early because we were used to that era of chlorpromamide and glibenclamide that Dr. Bailey was showing us. And we used to have those petrifying hypoglycemias with all their problems. Then when SGLT2s came, and particularly their ability, one, to give a reasonable control of glycemia, and two, cause some weight loss, we picked them up like anything. Now dapagliflozin has been available globally for about a decade. All said and done, if you look at the combination of these two molecules, one, in any person, as Sanjay Malhotra was just now saying, most of the patients with heart failure, he says hemoglobin A1C is nowhere near where he wants them to be. And all of us have been saying that every time we add an agent here, particularly people who have been on metformin, now suddenly having a hemoglobin A1C of, let's say, 8.59, and people being a little bit reluctant to insulin. Both of us know that an agent, oral diabetic agent alone would not bring it to where we want it to be. And if you give this combination, you can expect a drop of up to 1.5% of hemoglobin A1C. And here I want to emphasize what Professor Bailey was talking about right from the UKBDS trial. The first thing that does benefit to the heart and kidneys is giving a respectable reduction of hemoglobin A1C. We as clinicians, we as endocrinologists should never forget that side. Now, if on top of that, we have additional benefit of not having hypoglycemia, on top of that, not putting on an additional weight, makes them great drugs. And if in any way they help in reducing cardiovascular disease, which we know, in endocrine circles, we every time talk about the epidemic of type 2 diabetes. But many endocrinologists wouldn't know that the cardiac events have doubled up in India in the last 2 decades. There's an epidemic there as well. And heart failure is worst in diabetics. I'm saying, ask these both elegant senior professionals. Proportionately, heart failure is far commoner in diabetics than in non-diabetics, 2 to 3 times more. Treating it is much worse. When a friend was talking about giving sucralfate, valsartan, giving them beta blockers, giving them aldactone, blah, 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 the outcome would be worse in diabetics. So yes, if you have the initial advantage of a drug, which gives you a respectable reduction in hemoglobin A1C, a combination giving you up to 1.5, that in itself will give vascular protection, renal protection, and then on top of that gives an add-on protection. It'll be amazing. And also, we were probably the first nation which did not resist the combination therapy, because all of us knew, having a huge cohort of relatively economically less well-off people and educationally a huge handicapped population, compliance was an issue. So if today, as Professor Pancholi was talking about, if the same combination is available at a cheaper rate, and you can expect little hypoglycemia, you can expect, apart from whatever benefits would accrue as a consequence of reduction of HbA1c, additional cardiac and renal benefits. I think, as we say in Hindi, ye to sone pe suhaga, more than one ways of benefiting our patients. And if you do it at a relatively minuscule cost, I'm a delighted clinician as well as a planner.
Thank you, Dr. Zarkar. So, Dr. Bailey, 2 questions before I come to Dr. Pancholia. The first is that increasingly in the algorithms, do you think SGLT2 inhibitors may displace metformin? Because metformin got that first place slot with very skimpy evidence. The type of compelling data SGLT2 inhibitors have is reasonably robust now, and more is emerging. That's number one. And number two, there has been some data, though albeit retrospective, that when you combine a gliptin with an SGLT2 inhibitor, the likelihood of genital mycotic infections are much less. There is some rationale and science behind it, but do you really feel that it makes this a combination have a little advantage over say a metformin gliptin or a metformin SGLT2 inhibitor combination, because we are talking of combination therapies? So those are my 2 initial introductory questions, and then of course Dr. Pancholia will get in. We'll then address Dr. Mehrotra's issue also.
Okay, so picking up on your first point about why metformin and should metformin still be at the top of the tree, I think there is overwhelming evidence to support the position of metformin here. Firstly, we've got over 60 years of clinical experience, so we know the problems. And everybody appreciates particularly checking the renal function, watching out for hypoxemia, and knows that the end game, though it be very rare, is metformin-associated lactic acidosis. So metformin is there because it addresses insulin resistance. It doesn't cause hypoglycemia. It doesn't cause weight gain. It does help to reduce those cardiovascular events. And that long experience, I think, is still more than the experience we have with the other agents, and as a result, leaves it there. Your second point, which is a very interesting one actually, about putting the gliptin with the SGLT2 appearing to reduce mycotic infection. As you rightly point out, mycotic infection is the one issue here of tolerability, and there is strangely some evidence that the two agents together, the gliptin with the SGLT2 inhibitor, is associated with a reduction in the number of people who complain of genital mycotic infections. This hasn't been a consistent finding, but it has been noted on a good number of occasions. So it deserves looking into, and I think it could be an important factor in making sure that people are then comfortable to use and get the benefit of these two drugs together. If I can now go back to our cardiology colleagues, both of them made the point that by the time they see patients, they're usually advanced in their diabetes, and now, of course, they've got their cardiological problems, which is why they're seeing them, and that they're usually needing to deal with more than one, often two or three glucose-lowering agents. Both of them said that they're comfortable to use the various combinations, but that they were particularly interested in the added value that was given by the SGLT2 inhibitor. I was delighted in that clearly the cardiological community is now becoming aware of the value of these agents, and both of them pointed to affordability and also the potential value, particularly of the SGLT2 inhibitor in individuals without diabetes or in the early stages of diabetes to offer cardiological benefit. So I think that message is already coming home well, and it was a delight to hear those comments. Taking our endocrine colleagues' comments, it was what we all look at from the diabetes side, which is that it's not just macrovascular, it's also microvascular that we have to bear in mind, and therefore getting the glucose control early and effectively is the key to trying to prevent. And as you have mentioned, Chair, the hypoglycemia issue is so important. We have to do this without causing hypoglycemia, and of course by reducing weight if required. So those factors are dealt with by this combination, whether it be with metformin or indeed independently. And you've picked up on this issue of should we still keep metformin at the front of the queue? And I'm suggesting that the evidence is strongest, but our endocrine colleagues and yourself have both focused in on the degree of glucose lowering that you can get with the combination early. And I think this is very important because it's what we don't see. And what we don't see is microvascular disease so often if we can just get in early. So I feel that everyone's been very supportive of the key messages. It's always a delight to work with you guys.
Thank you, Professor Bailey. Dr. Panchola, you had a question for Professor Bailey.
Sir, you asked the question to Dr. Zargar about how early it is to be started. I think it is true in the patients with HFrEF, because in the trials it clearly showed the curve started diverging very early, and based on that issue, John McMurray and the Milton Packer, they come out with a new concept of rapid sequencing of all these frontline drug, and where SGLT2 inhibitor to be started first, along with the beta blocker, followed by ARNI and followed by MRA. So early initiation of this molecule is very, very important in HFrEF patients.
Can I turn this back to the cardiologists and say, how do you feel about the diuretics issue?
If the patient is on the diuretics, you have to reduce the dose of the other diuretics when the SGLT2 inhibitor is on the board, because we don't want to have a hypovolemic state.
Yeah.
But then patients who have, manifest congested state, diuretics would be still the drug of choice, and you have to be very cautious that you don't produce too much of diuresis. And I don't know how it helps. I mean, we have no idea about how the macrovascular complications are helping and how the patient's heart failure is coming down. Is it a glycosuric effect which causes volume depletion, or it has some other effect? I think we probably have some more time to understand that. But definitely, patients who are on ARNI and a combination of DAPA, their heart failure is, I'm pretty sure that a lot of patients are taken off from the list of a transplant, waiting for transplant. They go into class 2 symptoms from class 3 very quickly. And their number of hospitalization has come down drastically. I would say that at least 50% of the patient of mine who were hovering around ejection fraction of 30-35%, they've gone to 40-45%, and that's a significant improvement in their ejection fraction. They don't get heart failure anymore. So this is a wonderful combination, I would say.
So I think Dr. Sanjay, you have made a very good point that there is a reasonable evidence that in the heart failure clinics like what you see, the transplantation, time to transplant or the need for transplant, the movement to class 2 is better. So definitely there's an impact of these drugs in chronic heart failure. You also make a passing mention on acute heart failure, which Professor Bailey was alluding to. And in acute heart failure, just last week, some data is emerging, but this is early data, hemodynamically unstable data. So in that case, diuresis, ARNI definitely have their space, which is very well oiled there.
Correct.
If at all SGLT2 have to occupy that space, Professor Bailey did make a passing mention that they are now trying to grab that space with evidence.
I also, Dr. Joshi.
Let me complete. So in times to come, they will probably be there, but they have to be handled with care in unstable hemodynamics. So in stable hemodynamics, I think they are reasonably there, that their place is now inched, and they clearly are alternatives to beta blocker, ARNI, MRA, which has come up in a big way now, but they are there. So SGLT2 inhibitors cannot be dismissed in the chronic space. In the acute space, it's still work in progress. So I can see both of you all are very, aggressive on that. I'm keeping my endocrine colleagues a little out of this discussion. I'm getting Dr. Bailey back. Yeah, Sanjay, you're saying something.
So, I have become very, very, low threshold for somebody who comes with large acute myocardial infarction, as ejection fraction hovering around 35%, 40%, big infarct. I will start him on ARNI quickly. Now, question that 60 to 70% of these patients have diabetes in our clinics, which may not be true for West. And I asked this question to my diabetic colleagues that please change over to DAPA. And if I am changing over to DAPA, what is your worry about this patient going to hypoglycemia? Which drug you would like to stop or reduce?
Sambit, would you like to take that question? And then I'll go back to Professor Bailey. And then we'll come back to Dr. Panchola. He's also itching to talk on something.
Yeah, I think when there is an indication to start DAPA, especially in heart failure, I think we must start with an SGLT2 inhibitor, especially DAPA. And if hypoglycemia is a concern, better to stop or reduce the other drugs which are concurrently given, like sulfonylurea, or maybe we can reduce the dose of insulin. But definitely an SGLT2 inhibitor should be given in that case.
Dr. Sargar, any quick comment? You'll agree with that?
Yeah, understandably, ultimately it'll come down to two things. One, that there is a paradigm shift when you treat heart failure with or without diabetes. Previously many of those drugs that you just alluded to, or our cardiology friends alluded to, we will sequentially place them over a longish period. Make this change after 2 months, 3 months. Now those changes are made after every week or 2 weeks, to improve the prognosis. You wouldn't wait for such a long time. Even if you have an acute heart failure and you have a hemodynamic instability, you take a week or 10 days and then, add on a drug or two. And second important thing is, if a person is a diabetic, has presented to Sanjay's hospital with a reduced ejection fraction heart failure and has been on treatment, Samit very rightly said, incorporate SGLT2 inhibitors in the management, but in the process, you might have to truncate some other drug. Hypoglycemia would be a disaster in a patient like that, who has a heart failure, who is liable to have some form of a cardiac dysautonomia, and you throw a hypoglycemia and the fellow will get a dysrhythmic. So if he's on insulin, if he's on sulfonylurea, which a big chunk of our patients would be, that is where we need to truncate it. But we incorporated into SGLT2 inhibitors and there should be no problem that way. So in the process, Dr. Mehrotra would have to incorporate an endocrinologist / diabetologist in the management. He alone wouldn't be able to do that.
Fair point.
If he has to fine tune that.
Yeah, so Dr. Bailey will have the last word. Professor Bailey, two quick comments. One is role of SGLT2 inhibitors in the acute heart failure space, number one. And number two, diabetic versus non-diabetic scenario. The way these drugs have moved, the paradigm seems to be definitely a directionality or a trend towards a little earlier use. What's your first take on it?
Okay, if I can mold those two together,
sure.
It would appear that there's probably greater benefit with the reduced ejection fraction than there is with the preserved ejection fraction, although we still see quite a lot of heart failure in type 2 patients where the ejection fraction is reasonably well preserved. I'm not too sure whether or not we will consider the mid-range as part of the preserved fraction or not. But when it comes to considering non-diabetic individuals, I think it's important to look at the emerging evidence that probably SGLT2 inhibitors are altering the sodium hydrogen exchanger, which will then alter the ability to mobilize the calcium from the cells, which may well be a benefit to diastolic heart failure. So I see this as being an opportunity that the cardiologists can look into in greater detail. As far as the diabetes community is concerned, I think we are comfortable now that metformin, dapagliflozin, or any of the SGLT2s and any of the DPP4 inhibitors will not cause hypoglycemia. So I feel that our endocrine as well as our cardiological colleagues can all use all of these drugs with confidence that they're not going to precipitate hypoglycemia. And that, I believe, is one of the most important concerns that most physicians have, not to do any damage. So I hope we've at least shown that we've got 3 individual drugs here which can offer different types of benefits, and hopefully in patients who are not responding very well, we can put them all safely together.
Thank you. Thank you. So I'm going to do some rapid fire now because we are closing out in the last 5 to 7 minutes. I would expect just a one-line answer from everybody. Dr. Samir Dani, are you there? Would you like to make a comment or two, or you are in the procedure? I think Samir is still busy. So Dr. Pancholia, one quick liner from Dr. Madhusudan. When and whom should we look for heart failure with preserved ejection fraction in clinical practice? Should it be an NT-proBNP or a 2D echo?
The first and foremost, that the markers are very important. First, it is the NT-proBNP, and then echocardiography.
Okay. Dr. Mehrotra, in echocardiography, any specific thing you would like to be seeing there?
No, I will look at the ejection fraction, and I think all groups of ejection fraction, lower the ejection fraction, more is the benefit of giving drugs. So I would probably just sort of treat anybody who has ejection fraction less than 35%, or in the middle group, which is say now 41 to 49%, which calls minimally preserved ejection fraction. That's a new group. So anybody whose ejection fraction is more than 50%, I'm less worried. But anybody who has less than 50 and even lower than 40, I would be very aggressive in treating them with combination of all the drugs.
Sambit, Dr. Dhwani is asking the question, if DAPA Med has UTI often, what would be your approach?
Sir, can you repeat that?
If a patient on DAPA Med has UTI often, would you shift the patient to Vilda DAPA combination?
Yeah, if the patient is developing UTI recurrently, I think we should, if there is recurrent UTI, then we can think of stopping an SGLT2 inhibitor and can move to other drug that cannot produce UTI. But again, we have some evidences, as Dr. Bailey has told, that a combination of DP4 and SGLT2 have got lesser chances of genital mycotic infections. So you can go ahead with that.
Dr. Zargar, Dr. Akhilesh is asking that you are the senior most professor in the country. What's your clinical experience with vildagliptin 100 mg SR?
You know, Shashank, we just started using it for the last couple of months. And the only thing that it has done is, you know, if you look at the, pharmacodynamics and pharmacokinetics, now it has placed it at par with sitagliptin and linagliptin. You know, like we know that we used to give it past, looking at the Verify study, we used to use a combination of vildagliptin and metformin twice a day very early in many patients after that Verify trial, because of the benefit that at least that combination will work for more than 5-6 years in a good number of people. We did not have any experience with this SR preparation. But we also know every time you increase the number of tablets, the compliance goes down. And that has been our experience right from 80s. I'm saying, like, we were the first nation where we combined glibenclamide and metformin. And I still remember in 80s, so much criticism. ADA does say this against it. EASD says this much against it. It is unethical. It's not. But we knew our patients, and we knew that, giving those 20 tablets, that's why, all of us encourages even triple combination. So I wouldn't be, I would be a happy man if we have not only SGL2 inhibitors and DP4 inhibitors and metformin along with it in a compressed small tablet. I know my own population.
3 in 1 or 4 in 1. So we are now coming to Dr. Bailey. These are all one-liners, rapid fire. So Dr. Bailey, this is a little more provocative. Dr. DiFranzo is also a very popular speaker in India, or virtually of late, like you are. So Dr. Rawat is asking, can we advise McLeod to launch a DAPA-PIO combination in the NASH with diabetes, because NASH with diabetes is being increasingly discussed, or they have a new term called MAFLD. So do you think it's a wise thing to do, or would you still use a combination like a Vilda DAPA with it?
I think there's a distinctive difference these days between NAFLD and NASH, because NASH is towards the end of the line and you've got cirrhosis and you've got the clear evidence of problems that you can't reverse. And I'm going to leave that to the hepatologists to worry about. In the early stages where it is NAFLD and we're just dealing with the early symptoms of fatty liver, then I think we are in a different position where we are seeing benefit of pioglitazone, we're seeing benefit of GLP-1 receptor agonists. So we are dealing in a different ballpark here. If we are using just any agent that reduces weight, we should reduce NAFLD, and we should be able to not have to treat the NAFLD specifically. If it's NASH, it's too far down the line, we need to pass it on to the hepatologist specialty. I haven't really answered the question you asked because I I honestly don't know where I would draw the line, but I think I would draw the line at seeing that we've got ALTs adrift, ASTs adrift, gamma GTs adrift, bilirubins adrift, and there's clear evidence that the liver is not functioning properly if we've got other problems.
Yeah, Sanjay, you were saying something. Quick one-liner.
I am not able to understand that most of our patients who have uncontrolled diabetes with heart disease, they see the diabetologist all the time, and their HbA1c is not controlled. Do you think it's a patient-centric problem or a doctor-centric problem?
As far as I'm concerned, there is clearly a clinical problem here of nobody wants to treat something that the patient might be able to deal with themselves if they would just sort their diet and exercise. And 9 times out of 10, the patient will say to you, I promise, doc, next time you see me, I'll have lost those 2 stone.
Absolutely.
And next time you see them, they've gained 5 pounds. So I understand why there is a problem here. It's a shared problem. And all I can say is you have to do a bit of polite arm twisting if you can.
Sure, I agree with you.
That's a very nice way to put it, that it's a shared problem, shared decision making, and the ADA-ESD algorithm actually incorporated word of shared decision making. Patient is your partner in crime or care. So I say why crime and care, because it's ultimately care. We are all here for people living with type 2 diabetes or type 1 diabetes, and we are here to make their lives better. But you see, one thing is there, that they do not want to be happier. It's health and happiness is as important as outcomes.
It's only
and when it comes to lifestyle, now we have mango season here. Professor Bailey, I'm sure you were here and we would have given you some excellent mangoes from India. But you see, they cannot resist it.
Correct.
So the point is that human temptation is tough to control, and it's a behavior.
Is the winner.
So as I said, but having said that, we have now shared medications in pleiotropy of combinations with outcome data. For example, Professor Bailey today very nicely showed us data on DPP-4 inhibitors, and we have now a vildagliptin OD available, unique to India, across the world. And then we had DAPA. Both these agents are off label now. They are generic, they are affordable and accessible. So larger population will have access to them. And they have evidence base in the gliptin space. Professor Bailey very nicely said they are CV safe. They are not CV adverse for sure. And in the space of SGLT2 inhibitors, agents like DAPA clearly have a compelling data on heart failure, reasonably compelling data on CKD or TKD as they call it. So obviously we have very nice pleiotropy between these 2 agents, which are shared together. So I think that was the overarching philosophy of the presentation today. We had some extraordinary inputs from our 2 cardiology colleagues, Dr. Pancholia and Dr. Mehrotra. Professor Dani is still, he's one of the busiest Professor Bailey cardiologists on planet Earth. So I'm sure sometimes, he probably drives with a cath lab above his car. So he's that busy as a doctor. So I'm sure he's really pressing for an emergency, but he's an extraordinary friend of ours. And Dr. Das and Dr. Zargar, your pearls of wisdom were there. We do have, we missed a nephrologist. We have an emerging possibility of a hepatologist coming on board very quickly in this space. And but remember that it's all about the marriage of diabetes and vascular medicine. And I must urge everybody to read the journal Professor Bailey has been editing for a long time, Diabetes and Vascular Disease. It's a wonderful treatise. And I must thank our colleagues, both from the Medlive team as well as from McLeod's. My good friend Mahesh, Dr. Parthasarthi, and Priyadarshini, and of course Akshay Deshpande, who has put in a lot of hard work for this symposium. Thank you so much. And I must thank again, Dr. Mehrotra, Dr. Pancholia, Dr. Samir in absence, and of course Professor Zargar and Sambit Das. And Professor Bailey, I'm sure, though we are meeting virtually, maybe in another couple of months or couple of years, we'll see each other physically.
A big thank you to you guys.
Thank
Very
you.
much appreciated. Thank you for an exciting and insightful discussion.
Thank you.
Thank you.
Thank you all.
Thank you.
Dear sirs, I take the personal pleasure to offer the final vote of thanks. We thank you for the amazing session, and we are very sure that the insights that have been generated from this talk would help the audience to empower them in their clinical practice and ultimately lead to better patient outcomes. We thank our esteemed moderator, Dr. Shashank Joshi sir. We also thank our esteemed speaker, Dr. Bailey sir. We also take this opportunity to thank our esteemed panelists, Dr. Zargar, Dr. Pancholia, Dr. Dani, Dr. Das, and Dr. Berotra, respectively. Dear audience, we also thank you for sparing your valuable time to attend this session, gain insights, and empower your clinical practice. Last but not the least, we also thank our technology partners for aiding in the wonderful streaming of this webinar. Thank you one and all. Very good evening.
Thank you.
Good evening. Bye-bye.
Thank you very much.
Thank you.
Thank you.
Bye-bye.
Thank you very much. I just thought I'd say bye-bye. Take care.
Thank you, sir.
Thank you, sir. Thank you so much.
Thank you, sir. Dani is still logged in.